Hello, dear colleagues. My name is Mynzhylky Berdikhojayev. Almaty, Kazakhstan, National Hospital of the Medical Center of the Presidential Affairs Administration, Republic of Kazakhstan. We have a patient. 65 years old, gentleman, after stroke in right carotid territory, and he was previously recanalized on right ICA, then right ICA was stented, but patient stopped to take medication, and the stents were occluded, the stents, several stents. And now we have this situation. ACOM aneurysm. Okay, let's see. Internal iliac artery on the right side is occluded, on the left side it's stenotic. I think this patient also has a problem with patentia, but it's not the aim of this treatment. Yes, patient was stented on right ICA in cavernous segment, and then in cervical carotid, cigar stent were placed, but unfortunately, finally, it were occluded. Now, and after ICA occlusion, we recommended bypass, and bypass were placed from right STMC, but collaterals through the right vertebral to the right occipital artery, then external carotid to STA. And now bypass is functional, but external carotid is stenotic. The one reason is the cigar stent in cervical portion. Maybe we will place a stent in this portion, we'll see. Yes, bypass is working. Left vertebral is stenotic. V4 segment also stented. Credo stent were placed. It's working. Slight restenosis, but the artery is okay. You can see the stent. Stent looks like this here, but it's working. And on the left side, you can see stenosis in cavernous segment. It's eccentric, and there is a stent in cavernous ICA in upper portion, but ascending part of the cavernous segment is stenotic. More than 50%, and it's only carotid for today. From this side, and I think this carotid should be stented in cavernous segment. Stent is completely clear, it's diluted. I think it was a Nagomi Ultimaster, and aneurysm on ACOM. It's a high flow condition, that's why this aneurysm with risk of rupture. The artery is 2.4, the aneurysm size is 1.4. Unfortunately, we have no 1 millimeter coil. That's why the plan is stent monotherapy from right ACA to left A1. We have Acheros heel stent, 3x15. We will place Acheros stent. Okay. On 3D, it looks like this. It looks like this. That's why decision is to place stent from here to here. The right AC territory is feeding from the left side. This stenosis looks like this, and like this. We'll first of all place the stent in this segment. It's 4.5, but I think it's not the true size. Okay, let's see how this. Okay, let's measure. 3.7. We will take 3.5 millimeter carotid stent. We'll try to angioplasty with 2.5 millimeter balloon first, and then we'll place Ultimaster Tansei, which is 3.5 by 18. 3.5 by 9 Nagumi. Şarm toz Nagumi aşağıdır. Правым araç verirsen. My assistant Ravan Maratla, and operating nurse is Zoya. Anesthesiology team and the video support presented by Evgeny Grishayev, video team. Okay, let's see. The access with the 8 French short sheaths and 8 French MAC catheter angled from Boston Scientific, and then 2 Y connectors bolt, Riva Lure, and this is Teruma, or it's look like Teruma. Проводник 35-й на атағандай? Геникома. Teruma, no? Radiofocus, it's a radiofocus. Okay. Jojo, normal. And now we are in left ICA. Left ICA were also stented. It's very specific to our region. The most of the patients with atherosclerosis and multiple atherosclerosis, intracranial stenosis is common to our region because of the climate specifics and food culture, a lot of lamb and beef, kebabs, fatty meal, and also the stress factors. Yes, that's why this kind of atherosclerosis is very usual. Comparing with the European countries, I think you have no such kind of multiple stenosis patients. It's very specific for the Asians. Maybe it's a genetic, maybe the hypertension with the food culture is doing the bad work. Also patient diabetes var mı? Yes, and patient with diabetes mellitus. It's another problem. Huh? Okay, we prepared Nagomi 3.5 by 9. Balloon for predilatation Camus the one which is 2.5 by 9, and then we prepared headway 17 with Traxxas and the stand Achero. Okay, let's see what we can do. After treating the left side, I think we need to go to the right side for the external carotid territory. Maybe we will take a spider, not spider, the pronder protection device, and we'll do angioplasty for the external carotid stenosis, because external carotids now supplying the ST-MC bypass territory. Okay, now we are in the territory of MC. Okay. Anatomically, it's a territory of MCA and usually no problem. There is intracranial stenosis for MC also, but it's not the a problem for today. Treatment. Smart mask versa. На мак катетер интересен жақсайтын. Okay, let's do angioplasty. Patient under general anesthesia for today. So, maximum. It's a 2.5 millimeter balloon. We can inflate till 18. It will be 2.9 millimeter. Хорошо. 1.6. Okay, it's 18 atmospheres. Что назад? That's a pre-dilatation. Here's the Kamui. The profile of the Kamui balloon is very friendly, and for the intracranial stenting and angioplasty, we prefer to use Kamui balloon. Yes, it's also possible to use the other type of balloon, but the pushability of Kamui balloon is quite high comparing with the other type of balloons. Yeah, the artery looks like bigger than 3.5 millimeter, but I think yeah, basement very fast. 5,000 units of heparin I think will be enough. It's usual problem when you deal with such anatomy. Usually it starts touching the previous stent. That's a problem. Stenting. Так, cece yitiriyorsun. Cece yürüyor. Cece. Aldım ben Türk birisi. Ne yedim? Six biliyor. Yes, there is a problem. Yes, nominal pressure is 11. Okay, let's give 11. Umbrella, yes. Stop треш. Контур пересыш. Медленно. Все хорошо. Назад. As the nose of the balloon is touching the previous stand, that's why the navigability is limited. Ombro verir something. Назад. Yes, we gave 11 atmospheres and now we'll give 20 atmospheres. 20 verir. Yes, it's adaptation of the proximal port. Все назад. Все назад. Yes, we gave 22 atmospheres. Then stand became it's 3.5. It's needed 3.75. Подожди. Точно. Okay. Yes, it's far more better than it was before. The distal part is a little bit stenotic, but it's okay. We will follow the patient and the main part of stenosis is decreased. Okay. Now we need to find the projection. Yes, I think something like this, 49. 49 right and 6 caudal. And 6 caudal. It will be okay. The other problem could be placing the headway 17 through the previously placed 2 stents, but I hope it will be okay. Let's do it. That's okay. No, it's okay. One stent, and now we're facing the second stent. Yes, it's a problem of open cell design stents like Atlas, Pegasus, Neuroform, and coronary stents. Okay. The device is touching the vessel wall and stent wall, and then let's look like this. Stop. Yes, now it's okay. Вперед. Stop. Smart mask. Something okay. Yes. Today we have only braided stent Acero, and that's why we have no other possible options than Acero, but Acero is covered by heel technology, and it's also braided one. And we need to keep in mind this plastic tube is very short, and you need to keep in mind you should leave part of the pusher outside. Yes, you don't need to push the pusher wire maximum. I don't know why the company designed the pusher wire like this, and it was the problem. Huh? It's not so costly, but the Germans decided to do it like this. The Acero stent has its 3 points: distal marker of the stent, the medium marker, which indicate the aneurysm site, and the proximal markers. Distal 3 marker, proximal 3 markers, and 1 marker in the medium, which is showing where is the stent should be. It's only stent designed like this. Also, it has a distal marker which is pusher. Now we'll keep the proximal part a little bit proximal to the aneurysm. The stent is braided and it will shrink. Yes, now we located the medium marker at the aneurysm level. The stent is 3x15. It might elongate a little bit. Yes, the only problem is diabetes mellitus, and atherosclerosis on diabetes is very aggressive, and it's progressing very fast. Yes, it's not like this. We'll replace this catheter for any situation. Now stent is in place. We have one Acero stent. If it's needed, we can place it. Yes, now slight stagnation. I think it's enough. Acero is braided technology, and intima formation is very common, and usually it works very well. I think it's enough. We don't need to do anything else. Let's do AP and lateral, and then we will stent right common external carotid junction. At the end, maybe we will come to the left side and we'll check again the Acero stent. Yes, the bypass was done in June. Yeah. Yes, the catheter is working. You can see the MCA territory is partially covered by the ACA. That's why it's very important to protect the ACA. Okay, the proximal stent is working. 35 пересол. Стол лежит. 35. Yes, we're working with MAC catheter, and this introducer sheath from the Clever company. I feel slight friction, but it's not so much like with the Neural Max and the ballast with the destination, but there is some friction, but it's far more better. Okay, now we'll go to the standard territory. We have a 2.5 Camus balloon. Yes, we will use the Camus first. And we have a 3mm balloon from stand also. And geographically, the flow in the bypass is not so high because of the long way from vertebral artery to the common carotid. That's why to improve the circulation, I think it's indicated angioplasty and maybe stenting. Let's see, I never placed the stent inside the C-guard through the struts. There is a polymer. We need to rupture the polymer also. Yes, the artery diameter is nearly 3mm, less than 3mm. Balloon is in place. I'm not sure it will be easy. Yes, it's a C-guard stent and it works like a flow diverter in some situation. Yes, it works like a flow diverter stent. It's okay to prevent any kind of emboli, but when you try to place any device, that's why we recommend for the subclavian stenting, we don't recommend to use a C-guard. It looks like a flow diverter. Yes, it's an open cell design stent. It's nearly impossible. Huh? Okay. It's option number one. And the second option is we can take Traxxas with the headway. Yes, it's a little bit angulated. Traxxas has a smaller profile than 14 coronary wire. Let's try to do it. Even with the so nice plastic layer of the C-guard and flow modulation. The flow through the stent is patent. It's quite small, but it's patent, and it works like pump. That's why there is small hope we can go through the stent. Doesn't want to go. Yes, it was a period when patients stopped the medication, and at that time the stents were occluded. It doesn't want to go. Обычно... тағы бір Xeon Blue ашып бересінші? Yeah. Yes, it's very close to the orifice of the external carotid, but it doesn't want to go. Okay, let's try with the new Xeon wire. Maybe it will go. Okay. With the roadmap, it looks like we're in correct place. But with roadmap, in practice, it could be different. I will not torque the Xeon Blue till pre-shape the Xeon Blue, and we'll try to push it in a straight condition. Yes, and after this operation, I have one very specific device from Kazakhstan, which is guiding catheter from Kızılarda city. My colleague Nurlan designed the new catheter for interventions, which is Judkin strike catheter, and now available in coronary design. There is a quite interesting concept. Yes, it looks like subocclusion or nearly occlusion, and interestingly, we couldn't push any device inside. It might occlude it. That's interesting, huh? It doesn't want to go. doesn't want to go. It was a 3mm balloon. And now we try to go with the it's exactly at the point of orifice of the artery, but it doesn't want to go. Okay. Yes, it's very nice stent cigar. It's very nice stent. Okay, we are in the carotid artery. Okay, we faced at the orifice of external carotid. It will not go. Okay, it's impossible. Okay. Let's leave it for the nature. Nature can do it in the long term safely, and if artery is patent, then it could work. Okay. 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 Sometimes it's not possible because of the device, because of the structure of the pathology. Okay. I think now we a little bit occluded the, but it comes through the vertebral artery and no problem. Let's check the bypass. Yes, the bypass is patent. The artery will come back usually with no problem. Okay, let's stop at this level. And let's check the territory. Yes, actually is okay. That's okay. Now we can finish. Let's wait for the control CT. The CT is okay, then we can finish the case. And in the next 15-20 minutes, I will show the new catheter from Kazakhstan. And my colleague Nurlan asked me to show the potential of this catheter. We have some purpose for that video. I will try to explain. Okay, I will stop the audio. If CT is okay, Roland will show thumbs up. Okay, thank you.